Welcome to the Deep Dive. We're here to help you cut through complexity on challenging medical topics. Today, we're really plunging into something critical in orthopedics, knee dislocations and those tricky multiligamentous knee injuries. This session is designed especially for you, our orthopedic residents gearing up for postgraduate exams, like the FRCS or your fellowship exams. And just so you know, this deep dive is based on the fantastic author-made simple notes you can find over at mokyingren.sg. These notes were put together by Dr. Mok Ying Ren, who's a sports surgeon at National University Hospital in Singapore, and he successfully got his FRCS back in 2022.
That's absolutely right. And our goal today really is to equip you. We want you to quickly grasp the key clinical findings, understand their implications, get comfortable with the classification systems, and importantly, know the evidence behind the acute management and the definitive treatments for these really high-stakes injuries. So by the end, you should feel, well, a lot more prepared, not just for exams, but for handling these challenging cases in your actual clinical practice.
Okay, excellent. So let's start right where you'd first encounter this, maybe in the ED. When you're looking at that acutely injured knee, what are those immediate sort of alarm bells, the red flags you absolutely need to spot?
Well, one of the most striking signs visually is something called the pucker sign. What you're literally seeing is the medial femoral condyle buttonholing through the VMO, the vastus medialis obliquus muscle. And when you see that, it immediately tells you you're likely dealing with a posterolateral rotatory dislocation.
Okay, so it's not just a sign, it dictates the next step.
Exactly. The key takeaway is that a closed reduction probably not going to work, or at least it'll be very difficult. It strongly implies you're heading towards an open reduction, usually through a direct anteromedial incision right over that pucker. It's a clear signal of a very complex injury pattern.
That's a powerful visual cue. Definitely sets the stage. Okay, so beyond that specific sign, maybe after an initial assessment or reduction, what are the absolute must-dos early on for any potential knee dislocation?
Right. Your number one priority, absolutely non-negotiable, is ruling out compartment syndrome. You have to be vigilant, monitor closely, and alongside that, almost simultaneously, you must carefully assess for neurovascular injuries. This is often the biggest threat to the limb itself.
Okay, neurovascular. And we always hear about the popliteal artery in these situations. Why is it particularly, vulnerable when the knee dislocates like this?
That's a really good point. The popliteal artery's anatomy makes it uniquely susceptible. It's essentially tethered, kind of fixed, at three main points. The adductor hiatus superiorly, down in the popliteal fossa, and then at the soleus arch distally. So when you get that significant displacement, like in hyperextension or a dislocation, the artery can't really stretch or move out of the way easily. It gets pulled tight, kinked, or sometimes it just ruptures completely because of those tether points.
Right, those ankle points make it prone to injury. And it's not just arteries, is it? Nerves are often involved too. What about the common peroneal nerve? We hear about that one a lot. If that's injured, what's the prognosis usually like?
You're absolutely right. The common peroneal nerve gets injured in maybe about 25% of these cases. And unfortunately, the outlook isn't great. The prognosis is generally considered poor. We often see only about 50% recovery of function, which is quite sobering for the patient long term.
Yeah, 50% is definitely sobering. Okay, so we've identified red flags, done the initial crucial checks for compartment syndrome and neurovascular status. The next step is really understanding the extent of the ligamentous damage, right? Which brings us to classification. How do we actually map out what's torn?
Exactly. Classification is key for understanding the injury and planning management. There are two main systems you really need to know. First, there's the Kennedy classification. This one is based purely on the direction the tibia has moved relative to the femur. So you have anterior, lateral, medial, posterior, or rotatory dislocations. It's worth remembering that anterior is the most common type, maybe around 40%, and that type is often linked with traction injuries to the popliteal artery. Posterior dislocations, on the other hand, are more frequently associated with complete rupture of the popliteal artery, so the direction gives you some clues.
Okay, direction first with Kennedy. What's the other system?
The other key one is the shank knee dislocation classification, often just called KD. This system is incredibly useful because it classifies the injury based on which ligaments are actually torn. It gives you a structural inventory, if you like. So KD1 means only the ACL or the PCL is gone. KD2 means both the ACL and PCL are injured. KD3 is ACL, PCL, plus one of the collateral ligaments, either medial or lateral. KD4 is the most severe ligamentously. That's all four major ligaments, ACL, PCL, MCL, and LCL, PLC complex. And then there's KD5, which is any of the above ligament injury patterns, plus an associated fracture around the knee.
So Shank really tells you the shopping list of damaged structures. That seems really practical for planning.
It really is. It helps you immediately gauge the severity and complexity. A KD4, for instance, signals a much bigger reconstructive challenge than a KD1.
Makes sense. Okay, we've classified it. Now, thinking about acute management, maybe in the ER or early on, what are the options for getting the knee reduced? And you mentioned external fixation sometimes. Is there a key point about that?
Right. So acute management often starts with attempting a closed reduction under sedation. If that doesn't work, or if it's clearly irreducible, like with that pucker sign, then you'd move to an open reduction. External fixation is definitely an option, especially if the knee is grossly unstable after reduction, or if there are vascular issues needing stabilization, or significant open wounds. And if you do place an X-fix, the critical technical point is pin placement. You want your pins about 10 centimeters away from the joint line, both above and below.
10 centimeters. Why that specific distance?
It's vital because it keeps the pin tracks well clear of where you might need to drill tunnels later on for ligament reconstruction grafts, like for the ACL or PCL. You don't want those tunnels compromised by old pin sites.
Planning ahead. Good tip.
Yeah.
Okay, now let's move into an area that seems, well, quite nuanced and sometimes debated, the arterial assessment. We know the popliteal is vulnerable. How do we properly check it? And what's the role of the ABPI, the ankle brachial pressure index?
The ABPI is really your first-line objective tool here, after your clinical pulse exam, of course. You're comparing the systolic pressure at the ankle with the pressure in the arm, and the key threshold is 0.9. An ABPI less than 0.9 is highly suggestive of a potential arterial injury, maybe an intimal tear, even if you think you feel a pulse distally. It's that crucial initial screen. It can pick up injuries that might otherwise be missed, potentially saving the limb. Studies like the one by William Mills and JOT back in 2002 really highlighted this. They found all their patients with an ABPI under 0.9 did have an arterial injury needing surgery.
Okay, so less than 0.9 is a definite red flag, demanding more investigation. But let's break it down. What about the different clinical scenarios you might face regarding pulses and the ABPI? This seems key for decision making.
Absolutely. Let's walk through them. Scenario 1. You feel a good pulse, and the ABPI is normal, meaning 0.9 or greater. This is where, historically, there's been some debate about needing routine angiography. The current thinking generally is to discuss it with your vascular surgery colleagues. But the mainstay is very close monitoring. Serial physical exams, checking pulses, capillary refill, and repeat ABPIs, usually for at least 48 hours. Vigilance is key.
Okay, so normal pulse, normal ABPI means careful watching. What's scenario 2?
Scenario 2. You feel the pulse, but the ABPI is abnormal, so less than 0.9. In this situation, a CT angiogram is strongly recommended. That abnormal ABPI is your signal that something might be wrong with the vessel and you need to visualize it.
Right, abnormal ABPI triggers the scan, and the third most worrying scenario.
Scenario 3. Pulse is absent. This is a clear vascular emergency, no question. It requires immediate referral to vascular surgery. You'll likely need to consider applying an external fixator for stability, maybe even a temporary vascular shunt to restore flow quickly while planning the definitive repair. And crucially, you need to think about prophylactic fasciotomies, often 4 compartments, to prevent compartment syndrome from reperfusion injury after the artery is fixed.
That's a very clear algorithm, thanks. You mentioned the debate around angiography. What did some of those key studies like Stannard's or Weinberg's really add to our understanding? Do we always need an angiogram?
Well, James Stannard's group in JBJS in 2004 published important work suggesting a selective arteriography based on careful serial physical exams is generally safe. They found a good correlation between the physical exam findings and whether an angiogram was actually needed. They did highlight the need for extra vigilance, though, specifically in KD4 dislocations, those involving all 4 ligaments. And then Weinberg and colleagues found that if you have palpable pedal pulses and an ABPI greater than 0.9, that combination was extremely sensitive, actually 100% sensitive in their study, for ruling out a major vascular injury needing repair. So the evidence suggests that meticulous clinical assessment, combined with the ABPI, can often reliably rule out significant arterial injury, but you have to be thorough, especially with the higher energy KD4 type injuries.
Okay, so boiling it down for our residents listening. For those high-risk KD4 dislocations, you absolutely need serial exams for at least 48 hours. A CT angiogram is definitely needed if there's any history suggesting ischemia during the event, if the pulses are weak or CRT is poor, or critically, if that ABPI drops below 0.9. That seems like a solid framework. Now, shifting gears slightly, if you do need to get to the back of the knee surgically, perhaps for that popliteal artery repair, what's the approach?
The standard workhorse approach is the popliteal fossa approach. You'll have the patient positioned prone. The incision is typically a gentle S shape, curving medially as you go distally. When you dissect down superficially, you'll identify landmarks like the short saphenous vein and the medial sural cutaneous nerve. These lead you towards the apex of the fossa where the common peroneal nerve branches off the tibial nerve. As you get deeper towards the vessels, the mnemonic AVN is helpful. From medial to lateral, you encounter artery, which is deepest, then vein, then nerve. You might need to detach parts of the gastrocnemius heads to get full exposure.
AVN, medial to lateral, deep to superficial.
Got it. And if there is a vascular injury needing repair, you mentioned a sequence. It sounded quite specific, almost like a choreographed dance to save the limb. Can you walk us through that?
It really is a carefully orchestrated sequence, yeah. Time is critical. Typically, you start with the patient supine. The vascular team might place a temporary shunt first to get blood flowing again quickly. While supine, you, the orthopedic surgeon, would place your external fixator pins, usually lateral femoral pins, and anterior medial tibial pins. Then you turn the patient prone for the definitive vascular repair by the vascular surgeons. Once the repair is done, you flip back to supine briefly to connect the X-fix rods to the pins, providing stable fixation. And then often you'll go back prone one last time for the final checks and maybe the definitive vasculosynastomosis. And this is why concurrent fasciotomies are almost always needed during this process to handle the reperfusion swelling and prevent compartment syndrome. Wow, quite the process. Supine for shunt and pins, prone for repair, supine for rods, prone for final anastomoses, with fasciotomies mixed in. Lots of teamwork needed there.
Okay, so once the dust settles from the acute phase, the limb is safe, the vessels are okay. What about the ligaments? What's the definitive management plan look like for reconstruction?
Right, the definitive ligament management. Here, the concept of a staged procedure, which was well described by Mok and others, is often favored. The rationale for staging makes sense. Doing everything acutely can be, technically, very difficult, increases surgical time, and potentially raises the risk of complications like arthrofibrosis or stiffness.
So breaking it down into stages, what happens in stage 1? Stage 1 usually focuses on the extraarticular structures, the collateral ligaments. This is typically done within the first, say, 3 weeks. So you'd surgically repair or reconstruct the LCL and the posterolateral corner, PLC structures, if they're torn. For the MCL, the medial collateral, it often has good healing potential, so frequently you might treat it initially with bracing. You'd then reassess its stability, maybe around 6 weeks, before deciding if it needs surgery in the second stage. There are exceptions, though. If you have a Steiner-type lesion of the MCL where the ligament gets trapped and can't heal, or if the MCL is flipped into the joint, those would need acute repair. Sometimes a specific brace, like a Jack's brace, might be used to help the PCL heal in a good position, too, during this phase.
Okay, stage 1 is collaterals, usually within 3 weeks with a check on the MCL later. Then what's stage 2?
Stage 2 addresses the intra-articular ligaments, the ACL, and possibly the PCL, if it hasn't healed or wasn't addressed initially. This is typically done later, often around 6 to 8 weeks after the initial injury or after stage 1. This timing serves 2 main purposes. First, it allows the joint capsule to heal somewhat, which helps prevent fluid extravasation during the arthroscopy. Second, and perhaps more importantly, delaying the cruciate reconstruction seems to reduce the risk of significant postoperative stiffness or arthrofibrosis.
And you mentioned Mok et al. Did their study show benefits to this staged approach?
Yes, their findings suggested that patients managed with this staged protocol tended to have higher subjective scores, reporting excellent outcomes more often, and they also seem to maintain better range of motion compared to more acute combined approaches. So there's evidence supporting the stage strategy for potentially better functional outcomes.
That's really valuable information. Now, does having had a vascular repair change this timeline for ligament surgery?
Yes, it absolutely does. If the patient required a popliteal artery repair, you generally want to wait longer before undertaking major ligament reconstruction. The usual recommendation is to delay that definitive ligament surgery for about 6 months. This gives the vascular repair ample time to mature and become robust, reducing the risk of damaging it during the subsequent knee surgery.
6 months wait after vascular repair. Okay. One last difficult aspect, chronic foot drop. We heard the prognosis for peroneal nerve recovery isn't great, maybe only 50%. If a patient ends up with a persistent foot drop months later, what are the management options?
Yeah, that's a tough consequence. For chronic foot drop secondary to peroneal nerve palsy from the dislocation, the timing matters. If you're still within about 6 months of the injury and there's no sign of recovery, nerve exploration and possible grafting could be considered, although success rates vary. However, if it's been longer than 6 months, nerve procedures are less likely to be effective. In that scenario, the standard treatment becomes a tendon transfer. The most common one is transferring the posterior tibialis tendon through the interosseous membrane to the dorsum of the foot to try and restore some active ankle dorsiflexion.
Posterior tibialis tendon transfer for late foot drop. Okay, well, this has been an incredibly thorough deep dive. We've really covered the spectrum, haven't we? From spotting that critical pucker sign, the absolute need for immediate neurovascular checks, understanding the Kennedy and Schenck classifications, navigating the tricky decisions around ABPI and angiography, the complex surgical sequences for vascular repair, right through to the staged approach for definitive ligament reconstruction and managing late complications like foot drop. And remember, everyone, this detailed discussion is grounded in the excellent Ortho Made Simple notes, which you can find at mokyingren.sg.
Absolutely. It's a lot to process, but hopefully breaking it down helps. And as you take all this information forward for your exams, for your practice, maybe chew on this final thought. We talked about the evidence around angiography, how an ABPI over 0.9 might let you monitor closely. Yet KD4 injuries demand heightened vigilance regardless. How do you, in the moment, facing that unstable knee, blend that sometimes seemingly contradictory evidence with your own clinical judgment to make the best, safest decision for that patient right in front of you? It's about integrating the data with the art of medicine.
That's a great question to ponder. It highlights that constant interplay between evidence and clinical acumen, a perfect thought to wrap up on.
Indeed. And as you continue your dedicated work and study in orthopedics, let this wisdom offer some encouragement. The lips of the righteous know what is acceptable, but the mouth of the wicked what is perverse. Proverbs 10.32. May you always strive to know and do what is right and acceptable in your service to patients.